sure as going down with man flu as we speak, and felt that he wouldn't be able to do this justice. So, as you know from the previous blurb that Debbie kindly circulated to everyone, you got a tag team event tonight between myself and Professor Mererid Evans. And Mererid probably doesn't need a huge introduction because everybody knows her, but she is now a very eminent professor of clinical oncology based in Cardiff University with a clinical practice in Velindre. And I've had the huge pleasure of working with Mererid now for probably too many years to remember. And it's always a great pleasure to do this as a tag team event, and it gives us time to reflect on some of the journey that we've actually been on whilst we've been doing that. So Mererid, thanks so much for joining us on this talk tonight. I'm going to start sharing slides, and I'm going to do the first part of this talk, and then I'm going to be Mererid's slide changer, which is a true reflection of our working relationship over all these years. Can you guys see that?
Yes.
Yes.
Yeah. Okay. I'll put that. So I've lost you from so if Debbie, you're going to have to shout to me or something like that, because I've just lost the screen at the moment for anybody who's putting hands up. The normal order of this is there are questions at the end, but we're going to keep this as relatively limited. So please put your questions in the chat as you go along as well. So what we're going to talk about tonight is we're going to talk about the treatment of oropharyngeal cancer after the PATHOS trial recruitment is closed. And it'll become evident as to why we're doing that now, because we were privileged enough to be part of the PATHOS trial that essentially set the standard of care in many ways throughout the UK by recruiting patients into the clinical trial. And now we have a hiatus, having completed recruitment, until the trial reads out. So before we dive into the trial proper, I just wanted to give you a little bit of background as to why we ended up doing this trial in the first instance anyway, and especially as it's a mixed audience from all sorts of backgrounds. So the starting point for this trial is probably around 2004, when there were two papers, one European and one American, published back to back in the New England Journal of Medicine. And both of them said the same thing. They said, if you're going to treat patients with head and neck cancer with surgery, upfront surgery, and you get close or involved surgical margins and or extranodal extension, then you need to add in cisplatin to the adjuvant treatment. And that if you do so, you'd confer a survival advantage of about 6.5% to these patients. Now, both of those trials included a whole range of patients with head and neck cancer from all subsites, but the data that those trials produced became standard of care for the management of surgically treated head and neck cancer thereafter. But when you drill into the data around those trials, you realize that only about 15% of those patients were likely, to be HPV-related oropharynx cancer. And as we all probably know, that HPV-related oropharynx cancer was a new disease that emerged over the last 5 or 6 decades for reasons that were unclear, and for reasons that we're only becoming partially aware of. The strange thing about them is that despite presenting with pathological features that would normally be considered harbingers of doom in HPV-negative disease, these tumours do incredibly well when they're treated. And so that led us to the hypothesis of saying, how applicable are those data that were set in standard of care to HPV positive oropharynx cancer disease? And do we need to challenge that in some shape or form to test whether that's actually true, or whether we could reduce the treatment? So that's led to the PATHOS trial. It was conceived as a phase 2 trial initially because we had to prove feasibility, but we designed it that it would immediately roll through into a phase 3 randomized control trial. It was Cancer Research UK funded. In fact, it was Stand Up to Cancer Research funded. And basically, the hypothesis is that if you had patients who were managed with transoral surgery, patients with HPV positive oropharynx cancer managed with transoral surgery, could you safely de-intensify the adjuvant treatment? And if you did so, could you make sure that that doesn't confer a survival disadvantage? And does it confer a swallowing advantage? And so that's the premise and the hypothesis of the trial. And this is what it looks like. So essentially, you recruit patients that are operable by transoral surgical means. And that essentially means that they're T1 to T3 with ipsilateral neck nodes. The local MDT would have decided that it is entirely appropriate to manage these patients with transoral surgery in a neck dissection. And that's what they had. And then following scrutiny of their pathology specimens afterwards, they would be allocated to one of three risk groups. The low risk group, Group A, mandated no adjuvant treatment at all. The high risk group were patients who had margins, surgical margins that were less than 1 millimeter and or extranodal extension pathologically demonstrated. And they were randomized to either a standard of care 60 Gray in 30 fractions with cisplatin, as per the Bernier and Cooper data, or a de-intensified control arm with 60 Gray in 30 fractions. The intermediate risk group were patients who still required radiotherapy, but didn't have those high-risk pathological features, and they were randomized to have standard of care 60 Gray in 30 fractions or 50 Gray in 25 fractions. And as I've alluded to, the co-primary endpoint, there is a co-primary endpoint of the trial, and that's swallowing function as measured by the MD Anderson Dysphagia Inventory, the MD-ADI, at 12 months, which is a validated patient-reported outcome measure around swallowing function. That's powered for superiority in this trial, but the overall survival is powered for non-inferiority, and we therefore had to demonstrate that by de-intensifying the trial, patients weren't worse off from an oncological point of view. So we started in the UK. We ultimately ended up with 39 UK sites. And then beyond our wildest dreams, we ended up extending this internationally to 26 international sites across France, Germany, the US, and Australia. And the whole idea is that if PATHOS or when PATHOS reports, whatever the outcome, it's likely to provide a new international standard of care for the management of this disease. I love this slide. I didn't think it was ever possible. But from when we started recruiting in October, we finished recruitment in October 15. We finished recruitment in October 2024, a total of 1,349 patients to complete recruitment. This is the consort diagram, which is important. 1,350 patients were randomized, of which 1,274 underwent surgery, allocated to groups A, B, and C, as I explained before. And the take-home message is that 466 patients were allocated to Group B, 528 to Group C. And when they had the final withdrawals, we ended up with patients randomized in 416 in Group B, 394 in Group C. And that was an unexpected result that I'm actually going to come back to in a minute, because we expected when we started the trial that far more patients would be recruited to Group C than Group B. And I'll explain why that happened a little bit later on. If you look at the baseline characteristics of the patients that were included, there are no real surprises. 3/4 of them are male. About half and half of patients were previous smokers, but a significant number of never smokers or ex-smokers. Most patients were T1 or T2 as determined by clinical staging criteria to start with. There are very few T3 patients in here. Most patients had N1 disease, and most patients, 70% of patients or 72% of patients, were the tonsil subsite, which is exactly what you'd expect. If you now look at the pathology characteristics, because we've got those now, that mirrors the upfront clinical staging, where you've got 59% of patients with an ipsilateral level 2 lymph node. You have got a smattering of patients with one contralateral node, and that's worth an explanation. Entry into the trial was on clinical staging, but there were some units in an effort to obviate the need for contralateral radiotherapy, did a contralateral selective neck dissection. And there were a smattering of patients who ended up having that when it confirmed the presence of micrometastatic disease in a contralateral lymph node. And that's why those data are explained. As I've said, most patients were T1, T2 pathologically. TNM7 staging in this trial, and therefore most were N2A or N2B. Good news for the surgeons in the trial, the lymph node yields were good, way above acceptable, with nodal yields in excess of 20 to 30 and greater than 30 in the vast majority of these patients. And you can see the number of lymph nodes positive were varied, mostly 1, but right through to 4 positive lymph nodes of the trial. Probably the biggest surprise in pathological outcome for me, or for us, was how few patients had pathological extranodal extension, with only 27% of those patients. So what have we learned? So actually, very surprisingly and very heartening, we've realized that this approach, or we've learned that this approach is perfectly reasonable way to treat patients with HPV positive oropharynx cancer. We now know that in the control arms, not the de-intensified arms, that 3-year overall survival in groups, so that's the B1 and C control arms, is 97%, which is actually beyond our wildest dreams also. It also proves that we in the UK can recruit to multidisciplinary clinical trials, and we need to be proud about that and reflect on the fact that we can do it and not lose that infrastructure. We've seen a trend from transoral laser microsurgery approaches to transoral robotic approaches over the time, and I'll show you some data that sort of hints at postoperative function between the two strategies. That's philosophical, that's nothing to do with robots and lasers per se. So just to reiterate this again, this is our professional lives. The idea started in 2012. We put the first funding application in 2013. As I said, it had to be a phase 2 because we had to demonstrate feasibility. Recruited the first patient in 2015, managed to get 242 into the phase 2 trial, flipped to the phase 3 in 2018, and then spent the next 6 years recruiting to the phase 3, which takes us up to 2024. And then we've got 3 years to go, which is this hiatus then, which is going to take us up to 2027. This is what I alluded to before. This trial has been used in the UK to develop transoral robotic surgery, and that's only a positive thing. Since about 2020, there are about 500 patients who've had transoral robotic surgery because of this trial. And so what we've actually seen is this inverse proportionality, where as the number of patients increased having robotic surgery, the number of patients having transoral laser microsurgery decreased. And that was because lots of centres in the UK were using this trial as a way to start and pioneer their robotic surgery practice. I alluded to the fact that we expected a big difference in the Group B, Group C, and that was because when we started the trial, it was probably us in Liverpool who were recruiting to this most, and we were using transoral laser microsurgery, and as you'll come to see in a minute, you get closer margins with transoral laser microsurgery, and therefore more patients going into Group C. But the different approaches to transoral robotic surgery means that as the trial has progressed, there are wider margins, surgical margins, and therefore more patients are now going into Group E, to the point of equanimity when it comes to recruitment into Group B and Group C. The huge advantage of that is that we didn't think we'd be able to answer a survival outcome in Group B, and we thought we were going to have to do a meta-analysis of the data with Bob Ferris's ECOG 3311. But what's becoming evident now is that we can answer that survival question in Group B as well as Group C, which is a huge positive. Just switching to the outcome of the trials, James O'Hara had this idea and ran with the data, and we're extremely grateful to James for that. And I've also nicked his diagram just to explain the difference between a transoral laser microsurgery approach and a transoral robotic surgery approach. So transoral microsurgery, you deliberately do a transtumoral resection of the tumor to allow you to visualize the deep aspect of the tumor more appropriately, and then you take the tumor out in 2 pieces. and that allows you essentially to preserve most of the constrictor in most cases. If you have to take it, you have to take it, but that's dictated by the tumor. In contrast, the TORS approach, which is much more systematized, as Bert O'Malley and Greg Weinstein developed this in the UK and pushed it through the FDA, they had to have standard operations, and therefore a lateral pharyngolaryngectomy was performed and is still performed and still advised to be performed. And that means that you go to the deep side of the constrictor muscle as a matter of standard of care. So James wanted to compare what was the difference immediately post-operatively. So we were following data up at 4 weeks post-operatively and at baseline, obviously. And James wanted to compare the outcomes of these two different philosophical techniques. So he looked at length of hospital stay, nasogastric tube use, MD-ADI outcomes. He picked out what he thought were pertinent domains of the quality of life instruments we were using. He used a time water swallow test and video fluoroscopic swallow studies and designed appropriate statistics. So what we found was, or what he found was, that 508 participants were eligible for inclusion. Of these, 195 had TLM, 313 had TORS, and the grid that you can see there shows that these are equally balanced and all the things that you might want balance if you were comparing these two groups. If you look at length of hospital stay, you get 2 days on a median 2 days different, shorter stay in hospital if you have laser surgery. Nasogastric tube, there's a big difference, but that's skewed because a priori use of NG tubes is often used in transoral robotic surgery, irrespective of whether the NG tube is used afterwards. So that's skewed, but that's the data as it stands. If you look at the MD-ADI, all of those favored transoral laser microsurgery. As we look down the list of things that James measured, things sort of trended towards favoring TLM. And then we got to the water swallow volume, the various domains in the AORTCC 30 and the head and neck 35, and they weren't statistically different. So what are the limitations? Huge limitations. It's the non-randomized analysis. There are multiple outcomes. There's some missing data. And none of this data that I've just showed you matters a hill of beans if we don't prove, or if the data from the final trial suggests that margin safety requires wider margins. So if that's not the case, this becomes an irrelevant argument. But it was interesting to see as we measured at 4 weeks post surgery. So the conclusions were, and it's not surprising, if you make a smaller hole, you're likely to be less sore and you're likely to swallow better. And that's actually what we've demonstrated. I put the huge caveat that if the margins are not relevant, this becomes a moot point and doesn't matter. But what it might do, if the trial does what we think it might do and show that margins, that you can get closer margins, it might modify what you do with the robot in the end. Nobody's going to go back to using lasers. That doesn't work at all, but you might modify what you do with a robot eventually. And that was the tantalizing data that we got out early in this. None of this trial could have happened without this PATHOS, the trial management group. Max Robinson, as the trial pathologist, is a superstar and has kept us entertained. Chris has been coming up with scary numbers. When he came up with 1,000 for the phase 3, I remember being on holiday and thinking that's not doable. Kate and Joe are just outstanding colleagues, and the stuff they don't know about speech and language therapy, you don't need to know. And then Matt and Nachi have kept us honest and around the oncology side and the RTTQA that Mererid will explain more to you about in a minute. And our international colleagues, Bruce Hoey and Shaban Kandula in Florida, Chris Holsinger, Beth Beadle in Stanford, Ben Panizza, Sandra Prothedo in Brisbane, Haitham Magani and Pierre Blanchard in France, Vincent Gregoire and Christine Seaman, who were absolutely instrumental in opening this internationally, which we are eternally grateful. And then Suzanne and Silke Tribius in Germany. We're indebted to these people, and nothing could have happened without them. So that's my bit done. I'm now flipping over to Mererid. Mererid, can you see that okay?
Yes. Can you hear me?
I can hear you.
Yep. Thanks Terry. Noswaith dda, bawb. Good evening, everybody from Wales. I'm delighted to be here to pick up from where Terry has left off and maybe give a slightly more oncological perspective on this. So what can we say so far from PATHOS? Well, transoral surgery followed by adjuvant treatment results in high survival rates in PATHOS eligible patients with HPV positive oropharyngeal cancer. Our accumulating data shows 3-year overall survival in our control arms of around 97%. And until PATHOS reports, we think it's going to be 2028, early 2028, it's still a good treatment option for patients, particularly if there's a high chance that they're likely to have low or intermediate risk post-operative histology. So that would be PATHOS groups A or groups B. Click again, please, Terry. I guess that leads on to a number of questions. Can we predict who would end up in Group C prior to surgery? So these will be patients outside of the clinical trial that would need post-operative chemoradiotherapy. So that's triple modality therapy. These are patients with what is defined as positive margins, so margins of less than 1 millimeter around the primary tumour, or extranodal extension, and that would be pathological extranodal extension. And then if we're asking questions, we can cast the net wider and ask, almost 15 years on from when we started this crazy venture, is PATHOS still relevant? And does the de-intensification question still need answering in this patient population? And then if the answer to that is yes, then does de-intensifying adjuvant treatment after transoral surgery remain a promising approach according to all the data that has been accumulated in the interim? Next slide, please. So can we predict who would end up in Group C, i.e. in the high-risk group? So as I've said, these would be patients with positive margins or patients with extranodal extension. So this is data, our PATHOS data on 1,189 patients. Of those, around about 30% of them have ended up with less than 1 millimeter margin, and so would be in Group C of PATHOS or outside of trial would require adjuvant chemoradiotherapy. That still means that 70% of patients won't have positive margins and potentially won't need adjuvant chemoradiotherapy. I think there's a point here around appropriate selection of patients. So patients with early T-stage disease, with potentially tonsillar primaries, exophytic tumours. I'm not a surgeon, but I think anything that we can do to reduce that risk of having a positive margin. But as I say, the majority of patients will not end up with a positive margin. Next slide, please. What about extranodal extension, the other risk factor for ending up in Group C or requiring chemoradiotherapy adjuvantly? So Terry has already shown data that overall within the study, 27% of our patients had pathological extranodal extensions. That's extranodal extensions seen on post-operative histopathology examination. What we have done is to look at whether we can predict which patients will have pathological extranodal extension from looking at their preoperative imaging. So we have conducted a sub-study of 291 PATHOS participants recruited at 3 centres, Liverpool, Newcastle and South East Wales. And I will just give a shout out to the Liverpool team. So Abhishek Mahajan and Keith Hunter, and of course Terry, Executive Director of the whole enterprise, for your contributions to this sub-study. What we did in this sub-study is that expert radiologists, at least 2 expert radiologists, looked at each of these patients' preoperative imaging and scored them for the presence or absence of imaging-defined ENE. And then their post-operative histology, the corresponding patients, their post-operative histology slides were looked at by our expert pathologists to look for pathological ENE. Next slide, please. This is an image from our recently published paper. So the patient or the scan on the left-hand side, scan A, has no imaging detected extranodal extension, so a clear capsule around a lymph node with no disruption to the capsule. But the patients in B, C, and D do have evidence of imaging-defined extranodal extension. So you'll see in B that there is some fat stranding. I'm not a radiologist, but I've learnt a lot through working with our radiologists on this study. There is fat stranding out with the capsule of the lymph node in B, so that is imaging detected extranodal extension. It's the same patient in the coronal and sagittal images in C. There are two nodes that have fused together and the intervening capsule is no longer apparent. So that's imaging detected ENE. And then the final case is where the nodal disease has extended into the adjacent muscle. Next slide, please. So our results showed that IENE showed high specificity for PENE. So that means that when our radiologists said there was no IENE, it was highly likely that there was no PENE. That was the case in almost 90% of cases. However, IENE showed only modest sensitivity for PENE. So that means that when our radiologists were calling IENE, that didn't always correlate with the presence of PENE on the histopathology specimen. It correlated around about 60% of the time at best when cases with poor image quality and or with previous core biopsies were excluded. So the conclusion from that is that we can predict pretty well who won't have pathological extranodal extension, but not so well who will have pathological extranodal extension. And I caveat that by saying in this patient cohort, so you will know, as Terry has said, that these are patients with relatively early stage nodal disease, no bilateral nodal disease, no patients with nodes over 6 centimeters or with overt clinical ENE. They would not have been deemed candidates for transoral surgery and a neck dissection. So in the PATHOS cohort, this is the conclusion. So we have summarized from that the absence of IENE may be used to select patients for transoral surgery, i.e. if they don't have IENE, they'll be highly unlikely to have PENE on their histology and then end up in group C or with triple modality therapy. But the presence of IENE should not be used to exclude patients from being offered surgery because they may or may not have PENE. And so there are other things to be considered there. And maybe the overall conclusion of all of this is that we can't terribly reliably predict who will end up in Group C. Next slide, please. Okay, so onto the next question, is PATHOS still relevant? And this is a paper published in 2021 from the States, which concluded that HPV vaccination will only have a modest impact on the incidence of oropharyngeal cancer in the US until 2045. So that's about 20 years away, isn't it? By 2045, it will reduce the incidence of oropharyngeal cancer in people aged 36 to 55, but not in people older than 56 years old. As I've said, it projects another about 20 years of relatively stable incidence and a shift then in the landscape of oropharyngeal cancer to an older population. And it may be said that de-intensification may perhaps be most relevant in this patient population who, who potentially are less resilient to the side effects of radical head and neck treatment. Next slide, please. Okay, so the next question is whether the question of de-intensification for HPV positive oropharyngeal cancer still needs answering. And for this, there have been at least 2 very conclusive trials in the non-surgical setting showing that we cannot replace cisplatin with cetuximab concurrent with radiotherapy. So these were the de-escalate HPV study that many of you may have taken part in the UK, and the RTOG 1016 study in the US, both randomized phase 3 trials, which showed that overall survival was significantly inferior in patients who had cetuximab with radiotherapy compared to patients who had standard of care cisplatin with radiotherapy. Now, these trials really kind of rang an alarm bell that, you know, we cannot be changing treatment for even good prognosis patients without good evidence, robust evidence that it is the right thing to do. Next slide, please. And this is another study from the NRG led by Professor Sue Yom from the University of California. And this study looked essentially at reducing the dose of radiation and again substituting cisplatin, but this time with nivolumab. This started off as a phase 2 study comparing radical radiotherapy given usually in 7 weeks in 70 gray in the States over 6 weeks with concurrent cisplatin versus lower dose radiation with cisplatin versus lower dose radiation with nivolumab. And at 2 years, the progression-free survival in the experimental arms was significantly lower than in the standard of care arm, and the study did not proceed to the phase 3. And Sue Yom is an incredibly wise oncologist and woman, and she said in the ASCO post following this publication that de-intensification of chemoradiation treatments for HPV-associated oropharyngeal cancer is of very high interest to patients and to researchers, but our study makes clear that these approaches should remain experimental, at least until PATHOS reports. She didn't say that. She says she's still wise. Next slide, please. Okay, so the next question is whether de-intensifying adjuvant treatment after transoral surgery, does that remain a promising approach? This trial that Terry has already mentioned, the ECOG 3311 clinical trial, was a phase 2 trial led by Professor Bob Ferris from the US, which randomized HPV-positive patients after transoral surgery and neck dissection to receive either 60 gray of radiation adjuvantly or 50 gray of radiation adjuvantly. This was kind of the PATHOS intermediate risk group B patients with a few tweaks because we don't do things quite the same across in the UK and in the US, but essentially PATHOS intermediate risk patients. So it was the same randomization between 50 and 60 gray of radiation. Group B was the lower dose radiation, 50 gray, and Group C was the standard dose radiation, 60 gray. And in this study, 2-year progression-free survival with transoral surgery and 50 gray of radiotherapy was 95%. Very good outcomes. But the study said in conclusion that definitive, a changing practice would require phase 3 studies such as the PATHOS study. Next slide, please. So this study, ECOG 3311, has just reported long-term follow-up to 54 months. And in 359 evaluable patients, then you'll see I've highlighted in red arm B. This is the transoral surgery, neck dissection and 50 gray radiation arm. Progression-free survival still around about 95%. Overall survival almost 98%. And so in conclusion, Barbara Burtnest, who was first author on this paper, said transoral surgery and neck dissection with de-intensified postoperative management results in outstanding 54-month progression-free survival and overall survival, and that late recurrences were not increased when the dose of postoperative radiotherapy is reduced from 60 to 50 gray for intermediate risk patients. Again, not enough to change standard of care, but one does hope, or we do hope, that PATHOS phase 3 will be able to show similar results to this. Next slide, please. Of course, the next question is whether reducing that radiation dose from 60 to 50 gray will make a material difference to patients in terms of toxicities, particularly swallowing function. And the right one of those two curves at the bottom of the slides is a normal tissue complication probability curve for dysphagia, showing that as the biological dose of radiation to the superior pharyngeal constrictor muscle, which is clearly closest to the oropharynx, is increased from 50 to 60 Gray, the probability of dysphagia increases, almost doubles. Of course, that's theoretical modelling, but based on previous clinical data. Next slide, please. This is then the data from ECOG 3311. This is the MD Anderson dysphagia inventory, which is one of our co-primary endpoints in PATHOS. So arm B was the experimental arm here, where the dose of adjuvant radiation was reduced to 50 Gray. We'll see it 1 year after treatment and 2 years after treatment that the MDADI is around about 80 or just above 80 at 2 years. And 80 is a kind of magic cutoff that we've been taught by Kate and Joe. If you have an MDADI of over 80, it's pretty much normal swallowing function. You can see that in patients who received transoral surgery alone, the MDADI is higher, above 90. But it does seem to be lower, but not hugely lower in those patients in arm D. These are the ones who had adjuvant chemoradiation. And the patients in arm C and arm B are quite similar. So not much of a difference in this study in the MDADI at 1 and 2 years after treatment between the 50 and 60 Gray radiation arm. But is there a kind of more sensitive measure of swallowing function that we can look at? So next slide, please. This is recently published data by Kate Hutchison, who was the speech and language therapy lead on ECOG 3311 and also one of our co-leads for speech and language therapy on PATHOS. So this is VF data, so video fluoroscopy data in patients at post-transoral surgery at 6 months and then at 24 months. So you can see that the aspiration rates and high-grade dysphagia rates are lower 6 months after transoral surgery and adjuvant treatment in group B patients. So if you see that first curve, I've put a yellow arrow on it because I'm not in charge of the mouse. You can see that group B patients, the aspiration rate appears to be lower in group B patients than in group C patients, and that was statistically significant. But oddly, perhaps, but you know, all these things are things for us to think about and try and understand. By 24 months after treatment, they had become closer together, whilst the aspiration rates in arm A patients, so that's, you know, transoral surgery alone patients, remained low. It will be interesting for us to look at our PATHOS video fluoroscopy data to see whether we can replicate the lower aspiration rates at 6 months post-treatment and to see what happens on longer-term follow-up for our patients. Next slide, please. So this is my last data slide, and it's a kind of, I don't know, just a kind of a tale of caution, perhaps. So this is a study, recently published study in Lancet Oncology. Sorry, my reference has gone a bit odd at the bottom of that slide, I think. So it was a study conducted in the Mayo Clinic in the US, a phase 3 study of patients with HPV-positive oropharynx cancer who underwent transoral surgery and neck dissection and then were randomized 2-to-1 to either standard of care treatment. And standard of care treatment was in intermediate risk group patients, 60 Gray radiation, in high risk patients, 60 Gray radiation with weekly cisplatin. Or to the experimental arm, which was a hugely reduced dose of radiation, 30 Gray twice a day delivered in 2 weeks with docetaxel in the intermediate risk patients, and 36 Gray with docetaxel in the high risk patients. And the high risk patients here was any pathologically any and or multiple intermediate risk factors. So, you know, quite a different way of treating patients adjuvantly to how we've been used to in the UK. Maybe not surprisingly, there was statistically lower cumulative grade 3 toxicity rates, particularly dysphagia, at all time points between 3 and 24 months in the de-intensified arm. However, a note of caution, patients with extranodal extension and or TNM8-PN2 disease, and that's over 4 lymph nodes, had significantly lower disease-free survival than the standard of care arm. So, the conclusion is that this de-intensification or adjuvant de-intensification paradigm is not suitable for those patient groups. Okay, so I think I go to my conclusion slide. So in conclusion, transoral surgery followed by adjuvant treatment, we would say, results in excellent survival outcomes in ECOG 3311 and in our accumulating PATHOS control arm data. ECOG suggests that 50-gray adjuvant radiotherapy is sufficient in intermediate risk patients and may reduce at least early dysphagia rates, but we must wait until PATHOS phase 3 survival data matures before we change practice. The reduced survival seen with admission of cisplatin in non-surgical trials means that cisplatin should not be omitted from adjuvant treatment schedules until PATHOS phase 3 data matures. And just to kind of flag that PATHOS 10 was funded by CRUK last year. We're incredibly grateful for that. And that is being rolled out across sites. And again, grateful to our sites for being ready to bear with us and follow these patients up for up to 10 years after treatment with a kind of risk-adapted swallowing algorithm that will trigger VFs at 5 and 10 years after treatment for those patients who are showing signs of swallowing deterioration. And so, hopefully this will give us really valuable, important data in this young, relatively overall young, fit group of patients. Final slide, please. Just want to thank you all for listening. Diolch yn fawr iawn. Thank you, Terry, for putting up with me for all these years. And thank all our PIs across the UK and worldwide, and every patient who's been kind enough to take part in PATHOS. Diolch yn fawr iawn.
Thanks, Mererid. That's really good. Thank you so much. Okay, question time. So what's coming to the chat? Let me have a quick little look.
I think we can still see your slides, Teddy.
Oh, have you? Oh, I can stop sharing then. Let's do that. That's what I should do. Very good. So you've got a Welsh congratulations from Amy. So that's good. So are there any slides? You can put your hands up if you want. I can see any hands that might come up now. No,
it is late.
Got them into silence. Okay. That's good. So if there are no questions, just have one check. Jason.
There was always going to be one.
I felt pressure then to contribute.
Not from me.
I am driving, so if it goes quiet, I've gone the wrong way. Thank you so much. That was great. I really enjoyed and seeing all the updated work coming out. Really look forward to the publication. I guess Mererid, probably a question for you really. From that data, especially the Mayo paper. I mean, there are studies coming out of the US. Of course, they're all retrospective and database studies and case series, but the margins appear to be playing less and less of an important role in this disease. Sometimes because of the nature of the disease, but also the fact that single modality treatment is very salvageable. So the overall survival on these single modalities is often very high, even if there is a drop in the progression-free survival. And salvaging following single modality is also much easier as well, and can often be salvaged in single modality as well. And it seems from these, the data coming out, especially that Mayo paper, that the neck is the real key to the treatment for this, and how that adjuvant treatment is going to be decided in future. So I guess just a general question, if you could just comment on that and how you feel that adjuvant decision is going to go in relation to neck disease.
So I think you're right in terms of the margins around the primary and the data on that. It doesn't seem to be so prognostic, although at the same time, I would say that the majority of these patients do end up having adjuvant treatment. And so one doesn't know how, that is kind of almost making up for those margins if they're close. Only 10% of patients in PATHOS and in our practice beforehand, weren't having adjuvant treatment. So it's not to say that adjuvant treatment is not important if you have positive margins, but that, close and or positive margins followed by adjuvant treatment in the majority of patients, will yield good outcomes. I think you're right with regard to the neck, and many of you will know that there has just been published a new staging system for HPV positive oropharynx cancer, wherein patients with pathologically then patients with PENE will be upstaged one stage, if you like. So patients previously with PN1 disease 1 to 4 nodes will stay as PN1 if they don't have PENE, but if they have PENE, they will go up to having PN2 disease, and patients previously with over 4 nodes would have been PN2 disease will now be PN3 disease. And it's all based on data from many, many thousands of patients in the National Cancer Database in the UK, and it's incredible in the US, showing that patients with pathological extranodal extension have worse overall survival. So I think you're right. The neck is the key, and we can't mess about with the neck. And, I do worry about, giving these very, very low doses. I mean, in that Mayo paper, it seemed, and I haven't read it in huge amounts of detail, cramming as usual for talks the night before giving them, but it seemed that the reason for the poorer overall survival was higher rates of distant metastatic disease in these patients with, extranodal extension and or over 4 nodes. Good. I'm not sure whether I've answered your question, but I've tried. Terry, anything to add?
Yeah, that's great. It's just, thank you.
I mean, I think it's this classic case, isn't it? The more you think you know about this stuff, the less you do. And there's so much nuance. Keith.
Evening. I too am driving. I'm stuck on the M5 at the moment, so apologies if I drop in and out. Mererid and Terry, a question for both of you. But I guess at the time when PATHOS was set up, we were relatively happy with using P16 as our stratifier in terms of getting patients as HPV. That would not be the case now. Is there a possibility of using the 1,200 or so patients who have been recruited to sort of finally put to bed the whole thing of that we need an HPV specific test as well, which is how the new version of the data set is going to come out shortly once it gets through its various stages of the college. But it would be nice actually just to get some really robust data to put that to bed, if that would be possible within the PATHOS data.
Yeah, I'm not sure whether it will be possible, but it's something for us to go away and think about, because we mandated that patients had both P16 positivity and, a HPV specific test, so either ISH or PCR positivity for being able to enter the trial. So we don't have those patients where there are discordant results, I guess. So I think the advice is going to be that for clinical trials, you have to still have both. And the American College of Pathologists are not going to mandate that you have to have HPV specific testing outside of a clinical trial, but there are, a number of scenarios that they suggest that one needs both. So I don't know whether it's going to be a little bit divergent between the Royal College of Pathologists and American College of Pathologists on that, Keith, is it?
I suspect it is going to be for a while, although I get the impression that Jim Lewis is gradually coming round to our view of the world. So Max, I think, has been working on him for quite a while. So I guess, we shall see. And of course, we're not actually dealing with exactly comparable patient populations either. The European populations have been a bit different, and in terms of the way they were looking at the proportion of discordant results that there have been in the cohorts, it seems to be much more of a problem in a European population than it does in a North American population.
I think that's absolutely right, and that is the argument that is given for, you know, not mandating anything beyond P16 outside of some clinical scenarios. I think there are 6 of them. We've just written an editorial with Jim Lewis, so they're in that editorial. I should remember them. But one of them is clinical trials. One of them is, you know, weird oropharyngeal sites, so non-tonsil, non-tongue base. Crikey, can't remember the others. But, you know, and I don't know what your take is on this, Keith, but, you know, if a HPV specific test is carried out, then DNA-ish is not recommended. It would be looking for RNA.
Yeah, I think that's the case now, and I think we've gone through our DNA-ish phase and come to the shortcomings of that, and certainly now we are really happy to have RNA-ish now in place in our routine service in Liverpool. That's the one thing that has been good, positive about the way pathology has developed since over the last few years.
That's great.
Those who are on the call know the current issues that we're having.
Keith, thank you so much. Safe travels and good. So I'm minded of the time. The time-honored tradition is to not let these go for the full hour because for obvious reasons. So as there are no more questions, I'm going to wrap this up. But it just does leave me with one great pleasurable task, just to thank Mererid for coming to speak to us tonight. She
Thank you for
always
having me.
says yes and then totally regrets it, and then until we do it. So
I say I'm never saying yes to you again.
Exactly. Thank you all. Have a good evening. And
thank you,
by the way,
Nostan. Bye.
this is going to be a recording on the website soon. Debbie, yes?
Yes, it should be on by the end of this week, possibly
Perfect.
even tomorrow.
Have a good
Cheerio.
evening all.
Bye-bye.
Thanks very much. Cheers. Bye-bye.